Hello, this is Rick Wiggins from the University of Utah, and we're going to talk about degenerative spine disease and the importance of nomenclature when we talk about degenerative spines. So, we're going to talk about the importance of this nomenclature and how we discuss degenerative spine cases, review all those degenerative spine disease imaging, both with correlating graphic CT and MRI, and we're going to talk about how to recognize that degenerative spine disease and how to differentiate it on our imaging studies. I have nothing significant to disclose in terms of this material. So we're going to talk about low back pain. We're going to review quickly the spinal anatomy, and then we're going to talk about the important part, the degenerative changes and the imaging appearances of those changes and the verbiage, the words we use to discuss that, which is really the important part here in this discussion. Now, we know that low back pain can originate from any of the lumbar structures. So it can have muscular strain, ligamentous stuff may cause low back pain much more than degenerative changes that we see. So this is a big deal. A majority of low back pain is not something that we think about as imaging on cross-sectional imaging. A lot of it is from muscle strain or ligamentous injury. We see that a lot more than degenerative changes as a cause for low back pain. Now, because of that, we know that the correlation between pain and imaging is poor. There is not a good correlation between patients' low back pain symptoms and where it's arising from and what we see on cross-sectional imaging. So we want to be very careful about the words we use and how we describe these findings because that correlates with their therapy very importantly. And because of that, we know that conventional MRI, what we most commonly use for low back pain after plain film, is diagnostically insufficient in about 85% of those low back pain cases. Now, there's a very high incidence of back pain in our population. Somewhere around 45 for every 1,000 person per year has some kind of back pain. And the lifetime incidence is over half of us will have some kind of back pain during our lifetimes. The prevalence among adults ranges somewhere around 15 to 30%, and up to 5% of the population, that we suspect that's increasing, receives medical care every year from back pain. And it's a huge amount of visits just for a physician. Now, somewhere around 1% of the population may be completely disabled because of their back pain. It's probably the most common cause of disability in patients under 45 years. We wouldn't normally think about that. And the highest prevalence is in this big central age gap between 40 and 60 years of age. And it's a huge amount of money that's expended for back pain itself, for hospital visits and workup and time off work and everything else. Now, there are a lot of common causes that we think about that may result in low back pain. There are other less common causes, osteomyelitis, METs, obstructive uropathy, a whole bunch of different things, and some very rare things like usually tumors that we're thinking about here. Marrow replacing processes are very rare. That we also know that aging and disc degeneration is universal, happens to all of us. And if you think about the socioeconomics of back pain, somewhere around 80% of adults in industrialized nations are involved. In the US, it's one of the most common causes of disability. It's frequently involved in litigation. And spine scans are one of the most frequently requested of all imaging studies. It's very important. So again, the verbiage is important here, the words we use to describe these degenerative changes. So we'll briefly review the anatomy next. So the spine itself. Anteriorly, you have the vertebral body and the intervertebral discs between the vertebral bodies. And there's an ALL, an anterior longitudinal ligament, and a PLL, a posterior longitudinal ligament. So in the back, we have the pedicles going down, the transverse processes coming off to the side, the pars interarticularis, the different facet joints, the lamina between the spinous processes and the vertebral body, and the ligament of flavum that's between them. So when we think about a normal spine, we have the vertebral bodies, and then we have the discs between them with the ALL and the PLL between them. Those are the anterior structures of the normal spine. So posteriorly, we have another joint. We often see fluid in these with older degenerative patients where we have a facet with a superior and inferior articular facet surface and the joint in between those two. So the pedicle going back, the lamina going down to the posterior spinous process, and then the transverse processes coming off the side. So on a 3D reconstruction here, we nicely see the relationship of those facets themselves and how they articulate, correlating nicely with this graphic. And it's actually extremely complicated. Each vertebral body is actually a little bit different than the one above and below in that anatomy. Okay, so we'll finish up our discussion with the big important part here. We're going to talk about all these degenerative changes that we do see and what are their imaging appearances. And we're going to correlate them with the graphics, the CT and MRI, and talk about the correct verbiage that we want to use for these. Now, when we think about degenerative changes, we have a existence of something called normal aging. So there are some changes of the vertebral bodies and the discs that happen that we considered normal with age. Then we talk about the end plate degenerative changes. We have the discs themselves, the disc degenerative changes, and then facet arthropathy that can happen in back. So we're going to kind of start from the front and then go towards the back in our discussion. So again, normal spine. So we want to have nice vertebral bodies without significant anterior or posterior osteophytes, good disc material, and a lot of fat around the nerve root that's coming out under the pedicle above that level. So normal, nice T1 and T2 showing nice juicy discs here with bright fluid-like signal intensity. The bright fluid, we don't have big anterior or posterior osteophytes, no significant encroachment of the central canal, and we see that the discs do not extend out beyond the annular fibers at that level with a normal spine. Now, there is such a thing as normal aging spine with anterior osteophytes and loss of disc heights that we may see, with a little bit of degenerative changes predominantly anteriorly. It's thought of as normal aging. And like a lot of things in medicine and in imaging in our world, there's a lot of different staging systems we can use when we think about these discs and how we label them. There is a Fuhrman scale, for example, classification of disc degeneration. And as you can imagine with a young, healthy person, that is a grade 1 with a nice juicy disc, no extension posterior. That becomes more desiccated over time, and then we start to lose height with the grade 5 Fuhrman scale. More frequently on the neuro side on imaging, we talk about the type 1, 2, and 3 end plates. So those are the MRI signal in the end plates themselves. So type 1 is replacement of fibrovascular marrow. It is hypo on T1 and hyper on T2, and it may show a little bit of enhancement. Type 2 is replacement of that fatty subchondral marrow. It's bright on T1 and T2. And type 3 is more sclerosis. So that's a hypo intense dark on both T1 and T2. So we can think about that kind of as fluid, fat, and fibers. So type 1 fluid, dark on T1, bright on T2. Type 2 fat, bright on T1 and T2, fully suppresses on stir. And type 3 fibrous, dark on T1 and T2 on that imaging. So here's a nice example, sagittal T2, and we see very bright signal in the end plates on both sides. So that could be type 1 or type 2 when we first look at it. We're going to correlate the T1 and the T2. So here on T1, it's dark, and on T2, it's bright or stir. So if it's dark on T1 and bright on T2, just like the CSF, that's going to be fluid. So if it's fluid, that's the type 1 end plate changes that we see. Here's another example. Here's a T2, a stir, a T1, and a T1 post. So we see that these end plates at this level here, looks like it's bright on T2. It stays bright on the stir. It's dark on T1, and it does have some enhancement. That's a good appearance for type 1 end plate changes. So type 1, like fluid, dark on T1, bright on T2. So the type 2 end plate changes that we see are going to be bright on T1 and T2, like fat. So here's type 2 end plate changes. We see it's very bright here in the T1, similar to fat at that level. Another example here is a T1 and a T2 and a nice correlating pathology specimen. We see very bright T1 signal intensity within the end plates, and it's also bright on T2, looks almost exactly the same. And here you see correlating nicely, you see the fatty changes in the end plate. So that's a good example of type 2 end plate changes, like fat, bright on T1 and T2. So if it's like fat, when we do the stir, we expect it to suppress out, just like fat everywhere else. So these type 2 end plate changes you see, bright on T1, bright on T2, suppresses out on the fat sat or stir. So that's a good example of the type 2 changes. So type 3 is going to be fibrous. So we expect it to be dark on T1 and T2. So we see very dark signal intensity here on T1 within these vertebral bodies. So again, we can think about the type 1, 2, and 3 changes that way, the fluid, fat, and fibrous changes. So the disc itself, we like the disc to think about how watery we are. And those are about 85% watery in the first decade. But we see a decrease in that, somewhere around 70% of adults with desiccation and these annular fissures that we think about as being common after 60 years in age. So over time, decrease in water, increase in collagen, and that begins somewhere around the second decade and then progressive. So here's a past specimen we think about kind of as a normal disc. So normally at the disc level, you have nucleus. So this is the nucleus kind of on an H&E stain. Then we have a smooth cartilaginous junction. Then we have right here kind of a darker pink, that is the thin bone trabeculae. And then here you have normal hematopoietic marrow. So nucleus, smooth cartilaginous junction, thin bone trabeculae, and then normal hematopoietic marrow. That's what we think about as normal between the disc and the vertebral body itself. Now, that's a normal disc. When we have degeneration, everything is just mixed up. And you think about where the trabeculae is, where the marrow is, and the nucleus extending into the disc. That's what we see on pathology with degenerative disc degeneration. So on imaging, on CT, we think about that, all those in-play changes as well as the disc changes that we think about classically as degenerative changes. So we have little anterior osteophytes that we see here, and we might see posterior osteophytes that extend into the foramen, like we see nicely on this sagittal CT with this osteophyte almost completely encroaching this nerve root foramen at that level. Now, those osteophyte overgrowths, again, they can extend anteriorly, anterior osteophytes or posterior osteophytes. Facet overgrowth in that osteophyte formation may extend into the foramen or back posteriorly and displace those structures around it. Now, the disc degeneration itself that we see, we might see swirling of disc material. So every now and then, this axial T2 nicely shows the normal nucleus disc herniation extending out. So this swirling appearance you might see with disc material that's trying to escape the annulus with those degenerative changes. Now, when we talk about all these degenerative changes and discs and bulges and herniations and stuff, we want to try to be using the same nomenclature as everybody else. So in 2001, there was a large collaboration that discussed the nomenclature and classification of lumbar disc pathology, mostly led by the ASNR, the ASSR, and NASS, the North American Spine Society, to talk about this nomenclature and the exact words we should use to describe all of this. And it was actually a big collaborative project with input from a whole bunch of different societies to try to standardize the verbiage for discussing lumbar disc pathology. So that was kind of lumbar spine nomenclature 1.0 that came out in 2001. In 2014, there was the spine nomenclature 2.0 that came out that changed a little bit of the verbiage that we talk about. So the big change that happened there really was just try to make consistent verbiage for things that we talk about in our imaging on studies. Now, this is a big deal when we think about the different causes of low back pain, because a lot of them are not things we think about in cross-sectional imaging, and because we see a lot of things on cross-sectional imaging that do not correlate clinically to symptoms. We want to be very specific about the words we use, and we want to be sure we're using the same words as our referring docs and the surgeons when we discuss these findings. So the nomenclature, when we think about lumbar disc pathology, we have these different categories. Obviously, there's normal, then there's congenital development. Degenerative and traumatic is kind of the big issue here. There are nomenclature words and verbiage we want to use specifically for infectious and neoplastic and things we're not quite sure about, uncertain significance. But degenerative is the big thing here. So how do we differentiate normal from degenerative lumbar spine pathology? So first we'll talk about normal. So with a normal disc here on a nice gross specimen in the correlating axial T2 image, we see very nice disc material that's confined within the annulus itself. So we think about that as being fully and normally developed, and it's free of any changes of disease, trauma, or aging at that level. Again, nice path specimen at that level. So that's normal. So what is abnormal? So abnormal, we're often looking at degenerative changes. And when we think about those, we use words like annular fissure, degeneration, and herniation frequently. And if you look at these papers, both in the 2001 and the 2014 lumbar disc nomenclature pathology 2.0 version, we have some very nice graphics that guide us on the nomenclature. So first we have annular fissure at that level. We think about that as a separation between the annular fibers or separation of the annular fibers and their attachment to the vertebral bone itself. So we have disc material, like on this gross specimen, that is kind of extending out, often radially or transversely, through the many layers of the annular ligaments at that level. Sometimes this is referred to as the high intensity zone. Now, one of the big changes in the nomenclature 1.0 to 2.0 from 2001 to 2014 is they really stressed we want to say annular fissure instead of annular tear. So the word tear could be implied as traumatic etiology. So when we think about trying to be specific with this, we try to say annular fissure now instead of saying annular tear. This is sometimes called a high intensity zone. Now, this may have clinical relevance, but it can look almost exactly the same years later. So sometimes we see these annular fissures, bright signal within the posterior aspect of the disc material, and it is not clinically relevant. But again, we try to mention everything that we do see. So these may be asymptomatic, and that's a big deal for us on medical imaging because we know that we can't make that patient more asymptomatic than they already are from an incidental lesion. So we want to be very careful about potentially sending our surgeons to operate on a symptom. We want to find a finding that correlates with the symptom. So these annular fissures may be inconsequential, just part of the normal components of normal aging at that level. So depending on what type of study you do, if you do torture, excuse me, vertebrograms, discograms, where we inject contrast material in the disc and there is an annular fissure, there is kind of a rupture of that annulus, you might see the contrast material extending out, like in this case here. Normally we see these on MRI imaging. So on the sagittal imaging, like a T2 or STIR, we see a focal bright signal intensity within the posterior aspect of the disc material. At that level, that is consistent with an annular fissure. Now we might see that correlating with other words we'll get to: herniation, bulge, extrusion, but we look for that bright signal. So very bright here on the T2, looks like it's dark on T1, and it may enhance. That's a good appearance for an annular fissure. It's going to be bright on the T2 and STIR. And again, this is bright and has this appearance when it initially happens, but it might look essentially the same years later. So that's something we want to pay attention to. So next we have degenerative changes. So this is kind of the confusing areas. There's a bunch of different words we use when we think about degenerative changes. Desiccation, fibrous. We know that we lose disc height at that level. We have bulging of disc material beyond the disc space. We might see gas. We sometimes argue about, is this gas or vacuum phenomenon or air? We have degeneration of the annulus and sclerotic changes of the end plates and anterior and posterior osteophytes, all things that we talk about. Now, we sometimes discuss a big difference between what we think about as normal aging versus pathology. We want to differentiate the degenerative processes that we see around the disc level. So we sometimes use these words, they're more popular in the MSK world: spondylosis deformans. So that's something involving the annulus fibrosus and the adjacent apophyses. That's different than intervertebral osteochondrosis, OSIS, so pathology, osteochondrosis. That's involving the nucleus pulposus and the end plates of the vertebral body itself. And often we see extensive fissuring of the annulus fibrosus. So spondylosis deformans we think about as normal aging, whereas intervertebral osteochondrosis we think about as pathology. So these are very different things when we think about imaging of the patient. Sometimes we see what are thought of as degenerative changes, and that's just part of normal aging. That's okay. So with normal aging, we see fibrous tissue replacing that mucoid matrix. We talk about the discs getting less watery. The disc height is relatively preserved and the margins remain regular. And we see a decrease in the central T2 bright signal. And it should be relatively uniform among all discs. So if we see one that's different than the others, that's different. So that's all normal aging spondylosis deformans. We want to compare that to intervertebral osteochondrosis. That's pathology. So we have chronic discopathy, pathology of the disc, and here we have structural disorganization of the normal disc and changes with fibrosis. So we not only have those changes, but we also have osteophytes all over the place. We often talk about bulging of the disc that comes out. Osteophytes, end plate erosions, reactive osteosclerosis, so increased density of the end plates on CT, and chronic changes with the marrow at that level. So there's a difference between what is a normal vertebral body, what is normal aging with anterior osteophytes, and what is pathology with posterior osteophytes and a lot of disc changes. So a little bit of central loss of bright T2 signal can still be considered normal aging spondylosis deformans, whereas a lot of loss of height in sclerotic changes is thought of as pathology, intervertebral osteochondrosis in those cases. Now, there was some very interesting research actually looking at pathology specimens, and about 100% of skeletons of patients over 40 actually had anterior and lateral osteophytes. So anterior and lateral osteophytes are normal aging. But when they looked at 80-year-old pathology specimens, posterior osteophytes were found in only a minority. So that's very interesting. Anterior osteophytes are normal aging. Almost all patients over 40 have anterior osteophytes, but when you look at patients over 80, only a few of them have posterior osteophytes. So anterior osteophytes, normal aging, posterior osteophytes are pathologic. Now, when we talk about the disc material and what it's doing in relationship to the vertebral body, that's when we start talking about herniation. And there are a lot of different words we use to discuss herniation: herniated nucleus propulsus, ruptured disc, prolapsed disc, protruding, debit, disc extending beyond intertransition zone. A lot of different words that we use to describe this. But a herniation is a localized or focal displacement of disc material beyond the limits of the intervertebral disc space. So any kind of disc material, so that may be nucleus, could be cartilage, could be bone, could be annular tissue, or usually it's some kind of combination of all of those things. So we use disc material to be any of these things itself. Now, normally we want the disc to be free of any degenerative changes, whether those are age-related or pathologic, with no extension beyond the end plates themselves. And when we think about something that is extending beyond the end plates, we think about the percentage of the quadrants of the vertebral body itself. So is it less than 25% around? Is it between 25 and 50%? Or is it circumferential, more than 50% all the way around? So here, bulging is not considered a type of herniation when we think about abnormal lumbar discs. So we think about these quadrants when we differentiate a bulge from a herniation, and herniation may be focal or broad-based. So first we have a focal or localized herniation. So that's going to be less than 25%. So less than one quadrant, that's going to be a focal herniation. If we can imagine if there was disc material here at that level that was less than one quadrant. So here's a nice path specimen of a focal herniation. So here's the disc, here's the facets, here's the thecal sac, a little bit of normal fat around it. And this is a focal extension of disc material beyond the end plate, but it's less than one quadrant, 25%. So that counts as a focal herniation. And we can see those anywhere in the spine. So we might see those on the cervical spine. So here's a cervical on a axial T2. We want to differentiate that from a bulge, kind of a circumferential disc material. So that's not considered a herniation if it's bulging. It can be 100% all the way around. So if the disc material is extending 100% all the way around, so every quadrant beyond the end plates, that's circumferential bulging. So here's a nice graphic showing that circumferential bulging in a correlating case. Sagittal T2, we see what looks like some bulging anteriorly and posteriorly. And if it is circumferential, if it extends all the way around 100% each quadrant, that's going to be a circumferential bulge. Here's a nice myelographic study where we see that disc material all the way around. So it is posterior, it's lateral, and it's anterior. We have disc material circumferentially extending around that's going beyond the end plates. That's going to count as circumferential bulging. Now, we can have asymmetric bulging. It's going to be more than 25%, usually more than 50%. It may not quite be 100% around. So maybe there's one quadrant that's not involved. But if it looks like there's maybe 3 quadrants involved, that's going to count as an asymmetric bulge. That's often seen with some kind of adjacent deformity. We see this a lot with significant curvature, scoliosis of the spine. And again, if it's an asymmetric bulge, we're not going to consider that a herniation. That's going to be a different thing. So a herniation is going to be less all the way around. Now, you can have a broad-based herniation if it's more than 1 quadrant, but less than 2 quadrants. So between 25 and 50%, that's a broad-based herniation. So in this graphic, if we had disc material extending all the way out around this, more than 25%, but less than 50%, that's a broad-based herniation. So when we do have a herniation of material, we sometimes differentiate that from a protrusion from an extrusion. So here in this graphic, we see nicely that disc material, and again, it reminds us how it can be a combination of a bunch of different things extending beyond the end plate. That can be a protrusion or an extrusion. It counts as a protrusion if in any dimension, the disc material is always less than the origin site. So if we measure the outer margin of the disc of origin, the disc material that's displaced beyond that is always less than the origin site, the width of the disc material, and that can be in any dimension. So if the greatest distance between the edges of the disc material is less than the distance between the edges, that's going to count as a protrusion. And we can see those anywhere. We can see cervical protrusions like we see here nicely on the sagittal T2 of the cervical spine. Here's some thoracic protrusions. The disc material extending out is less than the base on this sagittal T2. And here's a sagittal T2 of the lumbar spine showing a lumbar protrusion. So those can be anywhere. So we differentiate a protrusion from an extrusion. If you have an extrusion, then in any plane, the distance between the edges is greater than the edges of the base of the disc material. So the distance right here of the disc material that's extending out is greater than the base of where the disc material is escaping at that level. And again, that can be at any plane. So that can be axial or it can be sagittal. So if we think about that dimension, if the disc material that's escaping is bigger top to bottom than its origin, than its base, then that's going to count as an extrusion at that level. And similarly, we can see extrusions anywhere. So here's disc material that's extending out. This is obviously much bigger top to bottom than the base, the site where the disc material is extending. So that's going to count as an extrusion at that level. And again, we can see that similarly anywhere. So in the cervical spine, here's a nice graphic showing an extrusion from the cervical spine and a nice correlating case from a sagittal T2 of the C-spine. And we think about the dimensions top to bottom of that disc material is much bigger than the disc origin where it's coming from. So that's going to count as an extrusion. Here's another case. Here's a sagittal T1 after contrast, and we can see some enhancement around this extrusion. Again, it's much bigger top to bottom than its origin, its base. So that's going to count as an extrusion. We can see it on the cervical spine or the thoracic spine. Here's a sagittal T1 and the correlating T2, and we have an extrusion of disc material behind this vertebral body. Again, it's obviously much bigger top to bottom than the base, the origin site of the disc material. If we give contrast, just like we saw in that cervical case, we may see some enhancement around the extrusion itself, but we think about this as being disc material arising from the disc at that level. So this is a sagittal T1 after contrast of a thoracic extrusion. It's much bigger top to bottom than the origin base is, so that counts as an extrusion. And we can see the same thing in the lumbar spine. So here's a lumbar extrusion. So again, the disc material bigger top to bottom than the bases, so that's going to count as an extrusion. So this is kind of our montage. So if the disc material goes all the way around 100 degrees, 100% of those quadrants, 360 degrees, that's a symmetric bulge. It's an asymmetric bulge if it's not quite all the way around. And then we can have focal protrusions and extrusions that we want to talk about at that level. So the extrusions themselves, we sometimes further divide them into different groups. So we can have a sequestration. That's if the displaced disk material loses continuity with the parent disk. So you may have some disk material coming out. Again, if it's bigger top to bottom than the base, that's a small extrusion. Then we can have a migration of disk material superiorly or inferiorly. And if it loses continuity with the disk material, then we call that an extrusion and sequestration at that level. So that part is a sequestration. And over time, as that ages, it may have different signal intensity than the disk itself. So here's a case. Here's a sagittal T2, here's a correlating T1, and the axial T2 and T1. So we do have some disk material extending back posteriorly. It looks like we have a little bit of soft tissue that's behind the vertebral body. And you see how its signal intensity is a little bit different than the disk on these levels. So we can think about that sequestration becoming more desiccated over time as it becomes less watery. So the signal intensity may be a little bit different than the disk, but you can imagine how this may have been migration of this disk material that lost its continuity with the disk and therefore became a sequestration. If we get contrast, we may, similarly to the extrusion, see enhancement kind of around it. And again, you see a little bit different signal intensity as well as enhancement around this soft tissue, but you can imagine how that may have been a prior extrusion with inferior migration at that level. And again, we can see those anywhere in the lumbar, thoracic, or cervical. Here's another case. We have some soft tissue behind the vertebral body on the sagittal T2, nice correlating stir and the T1. And you see on all these sequences that signal intensity is a little bit different than the disk. That's a good appearance for sequestration. And nicely on the axial, you see the soft tissue disk material behind the vertebral body and in front of the thecal sac at that level. Now, over time, this may become very desiccated and may actually calcify. So in this case, we had nice correlating CT. So we see very heavily calcified sequestration from this extrusion of disk material. So it was very dark on all the MR sequences. That correlates nicely with the heavily calcified appearance that we see on CT of this case. Now, if you have a sequestration, we probably at sometimes had extension of disk material superiorly or inferiorly from the site of extrusion. That's called migration. So with an extrusion, we can't have migration. That's signifying exactly that, displacement of that disk material away from the site of extrusion. So you can't have superior or inferior migration of disk material. And again, if that loses continuity with the disk itself, then we call that a sequestration. Now, if you have the disk material that instead of extending posteriorly anteriorly, if it goes through the end plate, we sometimes call that an intervertebral herniation. If the disk material goes into the end plate vertically in the craniocaudal direction to break through the end plate itself, we call that an intervertebral herniation, or if you like to name stuff after dead people, a Schmorl's node. So it can be very bright on T2. It might look very different than the disk material itself. This is a nice example of an acute cartilaginous node or Schmorl's node with an intervertebral disc herniation at that level. And it can be confusing, especially on contrasted studies. Here's a sagittal contrasted study. We see a lot of end plate enhancement, but you can see here nicely the disc material extending through the end plate. So that's an intervertebral herniation at that level. Here's another case. Here's a nice sagittal T1, the correlating T2 and stir image, and we see some disc material that is nicely extending. We even have a break right there in the end plate with the disc material extending into it. That's an acute cartilaginous node. It might be bright on the T2 or stir sequences at that level. So the disc material itself, often it's contained. So we have a displaced portion that is still covered by the annulus itself, but it may be uncontained. So then we don't have that covering itself. And as you heard from that discussion, we talk about the location. We sometimes guess the volume, which can increase significantly if we think about it no longer being under pressure. So sometimes we see a huge mass that we think could be an extrusion, but it looks like there's a lot of volume there. We know that that disc material can increase in apparent volume when it's no longer under pressure between the vertebral bodies. and we think about the content as we discussed. Now, and we talk about its location in different ways on the axial and the sagittal imaging that we routinely do. So on the axial imaging, we have central location, we have subarticular, we have foraminal, and we have extraforaminal out laterally at that location. And when we think about the sagittal view, we think about where the pedicle is. So here's the vertebral body, here's the pedicle. So we have a suprapedicular level, we have a pedicular level, we have an infrapedicular level, that's where we think about the nerve root usually coming out. And then we have a disc level, a discal level. So suprapedicular, pedicular, infrapedicular, and discal, the levels. So when we talk about extrusions and migration of disc material, we try to use these words to define that. So if we're off central, we sometimes call that a paracentral herniation. And if it's bigger top to bottom, again, we can think about that as an extrusion. So a nice graphic in a correlating case. Here's the axial T1 and T2 and the sagittal T2 showing this extrusion of disc material. And if it's off midline here, we can refer to that as paracentral herniation. If that herniation is out laterally going right into the foramen, then we're going to call that a foraminal herniation. So here's a nice graphic of a foraminal herniation on the axial and nicely correlating axial T2 showing that same thing. So on the sagittal, again, you have the pedicle right here. So suprapedicular, pedicular, infrapedicular, and discal level. So if we have herniation of disc material into the foramen, we can call that a foraminal herniation at that level. Here we have complete replacement of the fat. We want to see a nice keyhole shape where the nerve root foramen is coming out the pedicle of that same level, and we should see a nice keyhole shape with fat all the way around it when we think about narrowing at that level. We do sometimes differentiate kind of an acute from a chronic type of herniation. So when it's chronic, as we saw earlier, it becomes more desiccated and may heavily calcify. So again, we're going to think about all those levels when we discuss the location of the disc material that's escaping on either the sagittal or the axial views. And we know that if we do have a herniation that is coming out for a long time and is irritating the nerve roots, we may have a radiculitis from that herniation. So we might see enhancement of the nerve roots as they come out from a herniation, especially if there's a lot of enhancement around the herniation after contrast administration at that level. So that's the disc. As we move posteriorly, we have the facets we mentioned earlier. So we can have arthropathy and synovial cysts that happen to those facets back posteriorly. We think about osteoarthritis of those synovially lined apophyseal joints. So we can get degenerative changes that happen at that level. So frequently, when we think about plain film posteriorly, we have large osteophyte overgrowth that happens around those facet levels. Can be very prominent like we see these. These are almost extending back even farther posteriorly than the spinous processes themselves. It's pretty significant osteophyte overgrowth of those facets. So whether we're looking at plain film or axial CT examination, this is a good example of cervical facet arthropathy with osteophyte overgrowth on an axial bone algorithm CT of the cervical spine. So those may go out laterally, or we may see them predominantly posteriorly, as we see in this case with cervical facet arthropathy and significant osteophyte overgrowth back posteriorly. Same thing in the lumbar level. So we have a lot of facet overgrowth, a big differentiation between this side and what looks more like a normal joint with the facets, whereas on this side we have all this overgrowth. And we might see fluid in there or air density. We sometimes talk about, is this a vacuum or nitrogen, but it's air density at that level on the CT. When we correlate that with the MR, we see all that osteophyte overgrowth around those facet joints. So a nice example here, axial T2 imaging of the lumbar spine with lumbar facet arthropathy and osteophyte overgrowth wrapping around the facets at that level. And we might see a lot of fluid, like a joint effusion, in that facet arthropathy case at that level. So back posteriorly, again, we have that osteophyte overgrowth with all this osseous changes back posteriorly. We see here on this sagittal T1 image where we have too much osteophyte formation around those facets. And a nice correlating case again, if we give contrast, we might see a little bit of enhancement of that osteophyte overgrowth that's happening at that level. Now, we do have those facet joints that may have a lot of fluid in it, so we can get cysts of that fluid that may go anteriorly or posteriorly. If it's posterior, like we see here in this graphic, maybe not very exciting, but if it's anterior, it may encroach on those areas that we discussed as the central location and the foraminal going out laterally, as well as extraforaminal out there, and the subarticular zone where we think about those little nerve roots trying to get out. So here's a nice graphic showing fluid in that joint and a synovial cyst extending anteriorly that is pushing and displacing the thecal sac, and a nice correlating axial T2, again showing fluid in that facet joint and fluid here at that level. It may look like it's not contiguous, but often there's a thin connection between them. That's a good appearance for a synovial cyst that may be displacing the thecal sac at that level. So fluid signal intensity on MR or fluid density on CT. If we're doing a CT, here's an axial CT standard algorithm, and here's a myelographic image correlating case where you see that synovial cyst. This machine is just a big, stupid densometer, so we're looking at densities of stuff. This is fluid density. Remember, we can always measure that density at that level. And if we have a facet fluid collection, that's a good appearance for synovial cyst. We see them coming off right here. And what we think about as that central and subarticular, what used to be called the lateral recess area, that fluid density of a synovial cyst impinging the thecal sac significantly at that level. So fluid density on CT or intensity on MR with a synovial cyst going back here, we see on a sagittal T2, can significantly impinge on the thecal sac at that level. And again, we think about those locations on the sagittal as well as the axial with that fluid coming from that synovial joint going up. If we give contrast, we might see unusual enhancement around a synovial cyst that can be confusing at that level. Here's a sagittal T2, the T1 and the post-contrasted, where we see some enhancement around this synovial cyst that was extending back posteriorly. To finish up, we have interspinous degeneration, or bastrums, if you like to name stuff after dead people. So in the back, we have the spinous processes. If there's a lot of degeneration around them with the interspinous ligaments, we may have cystic degeneration of interspinous degeneration or bastrums at that level, with degeneration of the interspinous ligaments and the ligamentum flavum that is between them. Sometimes this is called kissing spinous processes. The spinous processes show degenerative changes between them, can be very sclerotic with close approximation of all those spinous processes with interspinous and posterocentral epidural cysts from that interspinous bursal fluid that can encroach centrally on the canal itself. So that's kind of from anterior to posterior, all the areas where we see degenerative changes of the spine. So when we think about spine degenerative disease, we want to remember all those different etiologies. There's a lot of things that can cause it. And the most common causes are not things we think about as imaging normally on cross-sectional imaging. Things like muscle problems or ligamentous injury. That's not stuff we see on imaging. So it's very important when we talk about spine degenerative disease to use the same words our referring doctors are using. So we want to be standard in our verbiage and our nomenclature that we think about. Remember, there's a big difference between posterior and anterior elemental disease. Think about adding the stir signal, especially if you're trying to differentiate those end plate changes. That can be very helpful. So there's a kind of a whirlwind tour of low back pain. We looked a little bit at spine anatomy, and we focused on those degenerative changes that we talked about and their imaging appearances. So think about that nomenclature. It's very important that we think about using consistent nomenclature in all of these cases when we discuss spine degenerative disease, especially because there's a lot of causes of low back pain that are not things we think about as imaging on cross-sectional imaging. So that's a discussion of degenerative spine disease and the importance of nomenclature. And I thank you very much for your attention.